one. So if you are interested in speaking and interacting with me, you can either use the chat, but I will highly invite you to maybe, you know, unmute or using and speaking to me rather than typing. It would be good, because essentially this is a psychology kind of session and CBT sessions, so the communication skills are very important. It would be good, so you would have some experience as speaking to me as well as doing some work today. Actually, there is a possibility we will go into role plays. Not sure how we could do this because we are so many people, but at least maybe a couple of you joining with me to demonstrate how to do things. Okay, so let's see what we are going to do today. And today it's going to be clinical interview. And if we didn't finish fully, what we will do is we will continue with it later on. So as usual, you know, we talked about it with your clients, or even when you're going to kind of come to the continuity of the second or the third session, we make an agenda, and in that agenda we put some items such as updating any questions in terms of that you didn't understand last week, anything I need to know to support you. So நாங்கள் ஒவ்வொரு முறையும் வந்து ஒரு அஜெண்டா வந்து செய்வோம். அதுல வந்து ஒவ்வொரு ஐட்டம்ஸ் வந்து எழுதுவோம். அதுல வந்து உங்களுக்கு கேள்விகள் இருந்தால், அல்லாட்டி நாங்க கடைசி தடவை என்ன படித்தோம் அப்படி என்று நாங்க வந்து பார்க்கலாம். உங்களுக்கு வேற ஏதாவது எனக்கு சொல்ல விருப்பம் என்று சொன்னா அந்த லிஸ்ட்ல அதுவும் வரும். யாராவது ஏதாவது சொல்ல விரும்புறீங்களா? நீங்க டைப் பண்ணுங்க. நோ என்று சொன்னா, எஸ் என்று சொன்னா நாங்க கண்டினியூ பண்ணலாம். So chapter use பண்ணி டைப் பண்ணலாம், அல்லாட்டி நீங்க உங்களை அன்பிளாக் பண்ணிட்டு நீங்க பேசலாம். Anything you want to put on the agenda that you would like to speak to me about, or we will just go on to updating if not. So யாராவது டைப் பண்றீங்களா? Yes, no, okay. Or we can continue. So I'm just waiting for you to kind of let me know, then we can continue. Can you all hear me? Can you all hear me? I would like to have some response from you to see that whether we need to kind of put certain things on the agenda. Okay. Yes, you can. Okay. Thank you, Bhavana, and thank you, Vidishani. So what we would like to kind of do that is to then continue. So if you're happy with continuing, you can put your thumb up, or you can just let me know if you need anything, so you can kind of you know, put it on the chat. Is that okay? So shall we recapture what we talked about last time? So we were talking about questioning, isn't it? So let's do some updating. What do you remember from last time in terms of, because we kind of did some of the things and we moved on to questions, and we quite quickly moved on to and we kind of ended the session. So I just want to go through it, just the last bit again, just to make sure about the purpose of asking questions. But anything that you remember from what we did last week, could you please type that for me? What did we do last week before we move on to the clinical interviewing today? Who remember what we did last week? And please do type. If you can speak, I would really love to hear from a couple of psychology students and a couple of medical students, because you're from two different faculties. So it would be lovely to hear what you are getting out from these sessions. So I'll just wait for you. Either I'll invite you to speak, but if you want to type, you can do that as well. So I'm just waiting for you to type again. What did we do last week? And what do you remember from last week? Distress tolerance, yes, we did speak about distress tolerance, and we talked about the feelings, emotions, and how they are impacting on our body, our thoughts, our behavior. So thank you for that. So anything else? Anyone else would like to come in? And perhaps you might want to put it in the chat for everybody so people can kind of join. We discussed about the thoughts, behaviors, feelings, bodily sensation associated with various emotions. That's really good. That's really well done. So anyone else would like to share what you remember from last time? Anxiety and anger. Wonderful, wonderful to hear that. ஸோ நாங்கள் வந்து எப்படி உணர்ச்சிகளை வந்து டோலரேட் பண்றது அதை பற்றி பார்த்தனாங்க. எண்ணங்கள், உணர்வுகள், உடல் அறிகுறிகள் எப்படி எங்களுடைய செயல்பாடுகளை ஊக்குவிக்கின்றது அப்படி பார்த்தோம். மற்றது பயம், கோபம் அதுகளை பற்றி பார்த்தோம். So anyone else remember anything? Yes, very good. Socratic questions and purpose of asking questions. That's really, really good. So we also started to talk about Socratic questioning, and I wanted somebody to say that so we can move on and we can look at that, because we came to the end. I'm not sure how much you understood. Would you like to write something about it? Then I know how much you understood about Socratic questioning and guided discovery. Actually, it's called guided discovery, and we do that through Socratic questioning. So we will talk a little bit about that. But how many did understand that? How many of you thought, that is something? Because it's important for me to know. I'm not sure how you make use of Socratic questioning in the Tamil culture or the Sinhalese culture or the Islam culture, because I know there are 3 cultures there, and whether it kind of set with you. And that's something I would like to speak about it today. So anyone would like to respond to that? What is your understanding of that? Do type. Let's move on, otherwise it's going to take a little bit of time. So keep, if you have an answer, either speak to me or just you can type and I'll keep reading. But so let's kind of move on and let's think about it. Could I ask again the psychology students to help me to translate some of the things when I go stuck? All the medical students, you can do that. And I know I was requested to speak in Tamil because the psychology students are doing their degree in Tamil, whereas the medical students are doing your degree in English. So so if you could help me out, and I'll be helping you as well. So the questions themselves guide the person towards analyzing everything and coming to the right answer. Exactly. So we don't give them the answer, we help them. And sometimes we don't have the answer genuinely. It's not because we know everything. So thank you very much for that, Bhavana. That's really, really good that you have very good understanding of that. And it would be lovely to hear from psychology students as well, because the reason I am encouraging the psychology students, and I think the medical faculty has been there and it is well established, and I believe it's the first time you are establishing your faculty, but you might come to understand that you are going to be the leaders in this field, because you are the people who are going to pass or come out and going to make some changes in terms of the psychology field. So I would really, really invite you to speak here, because leaders will have leadership skills, and it's very important when you're going to lead the field of psychology, because this is the very first, I think, time that you are kind of having your faculty consolidated and doing some work. So I will highly encourage you to kind of come out, as well as the medical students, to speak here. Like, maybe it's better to kind of speak and see how that goes. Okay, so that's just an encouragement from me. And let's look at it now in terms of the questions. And also remind me, if I just speak English, do stop and remind me to speak in Tamil, because there is a possibility I will just continue. Okay, so we know that why we are using these questions, and we talked about the guided discovery, and we talked about Socrates, and I thought like you would remember that, using his pictures and things like that. So we explore complex ideas to get the hold of the truth, to open up the issues which are very important to clinical interviewing. And I know some of you have said that you are here because you want to learn something about interviewing patients. Okay, so now we are going to look at some of the questions that we did. 5 areas. So do you remember the 5 areas? The situation, that's the first thing, isn't it? The situation, when whatever that is happening in the situation is one area, and then we are looking at the thoughts, feelings, bodily sensations, and behavior. So for that, we need to do guided discovery, and Bhavana has kind of said it there, why we are doing what we are doing, helping them to kind of answer some of the questions, because we don't know anyway. We kind of established they are the expert on their problem. We are not. So we are asking some questions and they are going to tell us. So it's almost like the W questions and how questions, because it's very open. What was going through your mind? What did what did you get in touch with as you were thinking like this? What did you notice in terms of this? And how did you cope with that? So these are the questions we are asking in English. And then, in Tamil, it will be like this, but then do you speak in this particular way to people? So that's very important to kind of think about. So it's good to see you, Safan. One face I can see. So உங்கள் மனதில் என்ன நடக்கிறது, நீங்கள் இப்படி யோசிக்கும் பொழுது உங்கள் உணர்ச்சிகள் எப்படி இருக்கின்றது, இப்படி. I don't know whether you speak like that in Tamil, but this is something you are teaching. In some way, CBT is a language. So you have Tamil language, you have the Sinhalese language, you have another language? No, probably not. Maybe, I don't know. Maybe English is another language in Sri Lanka. But what you are doing is then, in terms of, this language, you are doing additional language, which is maybe you can think like that. Because if this is not, kind of, you don't speak like this in your culture, then it's a language you are learning. And if you're learning this language, what you need to do is you need to teach your client the language, or your patients the language. If they don't understand it, you are not speaking. It's a bit like, I'm speaking in Danish, because I has no, maybe some of you speaking Danish, but but my prediction is majority of you won't speak Danish, because that's not a language you are familiar with. So what we are doing is we are teaching the clients the language as well as we are going. Let's look at the cultural aspects of this when we are asking this question and eliciting, whether it is the Sinhalese culture, Tamil culture, or the Islamic culture. What do we need to pay attention here? Are there any issues that we need to think about? This is something you can help me with because I have no clue. Because I was brought up in a particular way here. I was in Denmark, then I moved here, very much kind of got into the culture of CBT, if I could say CBT is a culture. And then if there is something that's going to happen, you are the experts who are going to notice, this is different here. So we need to pay attention to that. Does that make sense? I would really like you to say something about that. And, it would be lovely to have someone from the Islamic culture, the Sinhalese culture, and the Tamil culture. I mean, I don't know if there are more, and I'm really sorry if I'm, not including you. That would be the only reason, is because I wouldn't know. There are more cultures there. Do speak about it and do let me know, and then we can, think about it. Is there anything we need to think about in terms of asking these questions to your patients in a particular way? So please do type, and I would invite lots of psychology students to help me out here. I know it's a thought-provoking question, so it's okay. Take your time. So give some thoughts in relation to this. Let's say that you're seeing some client from Islamic culture. Let's say that you're seeing some clients from the Sinhalese culture. Or let's imagine that you're seeing clients from the Tamil culture. What would you be doing? Like, let's say that you are not Tamil or Sinhalese or this, coming from that background. Or you are just seeing people from your own culture. I know some of you have seen patients, because I think some medical students said that you are seeing people. So can you please type something or speak to me about it? Because, how do you work together in relation to that in the psychology field or in the medical field even? Do you have interpreters? Do you use interpreters if you cannot speak the language? What do you do? Would you know anything about how this goes? Have you given any thoughts? And even if you don't know, you can kind of start talking, because I don't know as well. I don't have any answers, but shall we talk a little bit about it at least? Sorry, are you saying anything? I can't hear if people are, if you're saying anything. Safan, did you say anything?
No, Meera.
Okay, you just want to go quiet with this. I mean, I don't know as well, so we are not going to go wrong. Let's talk about it, because
no, I don't know much about the culture either.
Don't know much about the culture either. Okay. So anyone else? Any lecturers? Anyone who is there who can help us out in terms of how you do this? I can speak about the UK culture, but I don't think there was a point talking about it, because it is in Sri Lanka. You are the future. So you are the one who are going to think about these things, about how to, how are we going to work with different people when different people are coming into our room. So in our context, whether it is the medical context or whether it is a psychological kind of context. Are there lots of similarities in the cultures? Or do you think it's too different? Okay, so we have someone. Okay, so the most doctors try to speak in the language of the patients. So that tells me that you all can speak all the languages, I guess. Okay, so that is really good. So what we do here is, if you cannot speak the language, well, they try their best to match with the same person. For an example, if there was a Tamil person, if there was a Tamil patient, they try to match. If the patient wants it, sometimes the patient would say, I don't want to see a Tamil doctor, or I don't want to see a different doctor, or Sinhalese doctor, or I don't want to see. So the people. Or an Islamic doctor. So they have the right to say that. They would say, well, I don't want to see people from this background. I'm coming from the same background. I don't want to see them. And they might say sometimes, no, I do want to see a Tamil doctor or Islamic doctor. Well, so the thing is, like, in some way that they can ask and say if they are from the same background. The reason is we have lots of people from, let's say, Southeast Asia who are coming from, and Middle East as well. So they are very much from Islamic culture. So if we have two people, a Pakistani doctor or Pakistani patient, let's say that they are from Islamic culture, it's just an example. And that Pakistani patient might say, I don't want to see him, because in our community, if I see this person, I don't know whether he would go out and talk about me. And therefore, I would rather see an English kind of doctor. So you have lots of options here, isn't it? But probably you don't have it over there. They are stuck with you, unfortunately. Or fortunately, I'm sorry, I'm just making fun of you. So they can come and ask like that. And if they see someone, if they are not happy with it, they can ask for someone else as well. But sometimes the first generation, basically, because the first generation, they speak the same language, and they might come and say, look, I would really like to speak to a Tamil doctor because I am a Tamil person. I don't want to have an interpreter. I speak my language very well, so I just want to see that person. So either they can reject you because you are coming from the same culture, or they say they want you. Mostly, according to the research, what we have been looked at in terms of culture, psychology students really pay attention for this, because you might do some research in relation to that when you're, in your third year, or I don't know, which year you are in. So in terms of the research suggests the second generation people, compared to the first generation, whether they are from, Pakistan or India or Sri Lanka or Africa or Nigeria, wherever they are coming from, it seems like the first generation prefer their own. The second generation, they don't want their own. It's almost like right opposite. They say, like, we don't want to talk to these people because it's almost like they don't understand. So there was a generational gap as well, because the first generation, they were thinking differently. Their thoughts are different. And then there was the generation changes. So there was a cultural differences between generations as well. And you are going to change that, because if the second generation who are just coming up, or the third generation or fourth generation, probably the fourth generation think, these people, what they did was not so great. But those who are in the field, the psychology field, or who are going to come up, you are the one who are going to lead your field. You are going to become the leaders in your field, and you are going to make changes culturally. You are going to think differently. And that is really, really important. So give some thoughts to culture. That's what I would say. And so here we have lots of acts, like equality acts. So ensuring that you are treating everybody equally, but that doesn't mean treating equally doesn't mean that you are giving everybody the same thing. Let's say we have vegetarians. I know the Islamic culture, they eat halal meat, or halal, and the Hindus will probably be vegetarians. The Sinhalese may be mixed, I don't know, and the Christian would be maybe mixed, or they would be vegetarian. And you are inviting them to one place. So you don't kind of give random food to them. You need to think about it. That's where equality comes in. Ensure the Islamic culture that they have their halal food, and ensure the vegetarians got vegetarian food, and those from other cultures, Christianity, or the different, I don't know, whatever belief system, ensuring they all have their food or what they like. That's how you are going to treat patients as well. When they're coming, they might have different needs. So when you are doing the clinical interviews, you need to think about it. Here we are taught, we are not from the same culture, but we are taught about all the other cultures. If you know your culture well, learn about the other culture, the culture you don't know. So Say for an example, let's think about the Hindu culture. So the Hindus, they fast for certain days. So you need to think about it, like when you are prescribing medication and they might not take it. But if they are not going to take it, you need to negotiate with them. You need to explain to them. So these are the fasting days. How are you going to take this medication or something? And especially antidepressants, when it is prescribed and everything, people think they can just skip for 7 days. And let's look at the Islamic culture. There was a Ramadan will come up, isn't it? And that's like a long kind of fasting. So we do need to have a kind of clear conversations about when they are going to take the medication, because they can eat at a point. So you need to think about it, and you need to give some thoughts to the medication itself, what they are taking, things like that. So you do need to become, so there's a little bit work you need to do. If you don't know the culture, if you don't know the country, if you're in a country where you are living together, and if you don't know the culture, let me say this, you better learn about each culture and better respect the patients who are coming from different cultures, because you are the future and you are going to take care of them. Is that okay to say that? Anyone has any objections, please type, and I would like to hear about that before moving on. But how did you feel about this? So I just want to hear a little bit. I would really like to hear your opinion, because none of you spoke anything here. You went absolutely numb and quiet when we talked about culture. So I have given you a speech, and I would really like to hear something before I'm moving. I'm still waiting patiently. Maybe you might want to type something. How are you going to, look after your patients if they are coming from different cultures? And how would you give some thoughts? Would you be interested in learning? Because that's the other part. When you are learning a human being, you are respecting their culture and you are learning. Yes. Exactly. So that is very good. So you're absolutely right. Unless we know the culture of those we are talking with, we can't understand them completely. Okay. So that is really, really good to hear that. And sometimes there is a possibility that, different cultures would want to interact with the different culture. Maybe there's the Islamic culture would like to have a Hindu kind of doctor to talk to, because they feel like their culture is not understanding them. Likewise, the Hindu person might say, oh, I would like to have, so I'm talking about religion actually rather than culture, but might say I want to have an Islamic person or different person. The Sinhalese might say I want to have a Tamil doctor, or vice versa. Whatever that you are going to do, that it is about giving that support to the patients that you are coming in touch with. Okay, so let's move on. So this is where we are talking about clinicians' attitude and therapeutic relationship. Anyone want to talk about it? What is therapeutic relationship or doctor-patient relationship? How do you do that? So I would really like to hear from the psychology students here, because it seems like you are not speaking at all. So please help us out. What is the attitude? How do we do that? Because this is all, we are going to move into clinical interviewing. The more you are responding, the quickly we will kind of cover that. Okay, so what do you think? What is therapeutic relationship, or what is the doctor-patient relationship, if we could say that? We talked a little bit about this. I'm waiting for you to type or speak to me. So maybe நான் தமிழ்ல வந்து சொல்ல மறந்துட்டேன். உங்களுடைய டாக்டர் பேஷண்ட் ரிலேஷன்ஷிப் அப்படின்னு சொன்னா எப்படி நீங்க வந்து அவங்களோட வந்து பழகுவீங்க, உங்களோட attitude எப்படி இருக்கும்? அது தமிழ்ல யாராவது சொல்றதுனாலும் சொல்லுங்க வடிவா. அதை பற்றி கொஞ்சம் சொல்லுங்க. எப்படியான குவாலிட்டிஸ் எப்படி இருக்கும், அதுண்ட குவாலிட்டிஸ் என்ன வந்து நீங்க வேல்யூ பண்ணுவீங்க, என்ன எப்படி இருப்பீங்க நீங்க, உங்களோட குவாலிட்டிஸ் எப்படி இருக்கும் நீங்க ரிலேட் பண்ணிக்கல மற்றவங்களோட. So I just repeated that in Tamil. So I'm just waiting for you to type. Today you are not being kind of, it's kind of Sunday, isn't it? Okay, let's look at it. So it should be confidential, genuine, and hospitable. Okay, yeah, that's really good. So we are talking about some boundaries. It should be confidential, it should be genuine, and it kind of welcoming kind of relationship, warm kind of thing. So let's kind of look at it. So what we are saying here, we are saying that in terms of relationship, both clinician and therapist and the patient or client, or however you want to say it, have valuable contribution to bring to therapy, because you both have knowledge. Somebody raise hand. If you want to speak, please do speak. You don't, or is it a mistake? So yes, both clinician and therapist, patient, client have valuable contribution to bring to therapy. And relationship is the partnership in which both clinician and the patient, they work together to reach client's goal. Is it your goal that you're going to reach? No. So it's the patient who is coming and they have a problem, they have a goal, and you're going to work together to help them. So how is the interpersonal skills? How are we relating to them? Appropriate empathy, not too much like you are falling apart and crying, because when the client is crying and you say, oh yes, it makes me feel sad, I'm going to cry with you as well, and holding on to them and cry. No. So it's about appropriate empathy as well. So it's just ensuring and acknowledging their problem through verbal kind of gestures, but also your body kind of gestures. So the body language. Am I making sense? Please do type as I am speaking. I'll be very happy to learn from what you are thinking about this. Is this new to you? The relationship aspect. Do let me know if this is new to you. So appropriate empathy and understanding, warmth and genuineness, and showing such acceptance and liking within boundaries. So it's not too much liking, because so we know that we talked about ethical guidelines. It's not about, oh, that's a beautiful patient or something like that. That's too much liking. But when you are kind of showing liking and acceptance, we are talking about that you are welcoming them. And you are making them sit down, you are helping them to talk about these things. So then the patient says, oh, I really like you so much, I would like to invite you for a cup of coffee. And that's like, then you need to think about the boundaries. Oh, that is something we don't do. So that is the professional, when we are talking about professional boundaries. And there is a possibility, like, clients from different backgrounds, it happens to our service, if they really like, and if they are improving, they would bring some food to us and say, I would really like to eat this, or something like that. So these are the things you might want to kind of establish in your culture. I'm not going to talk about it, because that is for you to establish about what is accepting, what you can accept and what you cannot accept. In our service, they say like anything over 20 pounds. If somebody bring anything over 20 pounds, we need to return that to them. We cannot take it. But if it is kind of under 20 pounds, it's just a small gesture. They want to give it to the service, something, or flowers or something, that we can put it in the reception, or they want to bring some chocolates that because they felt really good and they are celebrating, they are feeling better. So we put it out for everybody, all the clinicians, they can come and take it and things like that. So that's where you need to kind of negotiate the professional boundaries. If somebody is coming with a gold chain or something, you need to return that, because that's more than 20 pounds. So things like that, and kind of instill confidence and ensuring those boundaries. So they are professional boundaries, and sometimes you need to kind of, you wobble a little, finding a balance where you are in terms of that. And culturally, it has an impact how people relate. And maybe from my understanding, people from different culture, they will start to call you doctor, and then soon they will call you sister, brother, because they kind of feel quite close to you. And if they are from your own culture, they would start to change that. They would just start to kind of say sister and brother, and you might smile, you might say, you know, you can call me by my name. So, and when people try to call me, oh, doctor, things like that from the Tamil culture, I always say, please call me Meera. And then you know, sometimes they end up calling akka, something like that, or sister, or something like that, or they will call you amma or something like that. But that is also, you have to kind of negotiate in terms of your relationship. If you're happy that they do that, it's okay. And for me, I don't mind, because you know, that's how they would refer to me. But when the relationship's coming to an end, and it is coming to an end, well, because you have contracted certain things, okay. It might not make sense to you unless you are working with clients, and I am offering this to you as you are working with patients. And this is something you might do in the future, or you are already, because I know some of you said that you are seeing, but certainly you are not going to start to see any clients for CBT, that's for sure, because that is something we have established. That's our boundaries. You are getting some teaching and you're learning this, but you might not, you know, apply this therapy, or not offering therapy. So so that's okay, but you can use your skills to speak to your patients. Okay, so let's move on. So that we are going to move on to the assessment skills today. Let's look at it. And I would really like you to kind of involve and help me with this, because it would be a shame. It would be a shame if I am just speaking at you, or speaking to you, if you don't understand it, because we are going a little bit more or deeper into it, because I put something for you to understand. Which context? I created a context for you. There was certainly a cultural context. There was a religious context. And there could be also gender differences, so which I didn't speak about. Maybe females would like to see females, men would like to see men, or vice versa. I'm not sure. So these are the things that we need to look at. So there's a context, and we are going to kind of assess, and we are inviting them. Or you are kind of going to the hospital, or you have a base to kind of do this work. So the aims are like to outline and practice structured interviewing, because it got to be structured, isn't it? And to assess clients' main mental health difficulties and the impact this has on their daily living, because that's the purpose. Why are we doing this? We need to have something structure, and we are kind of looking at the patient's mental health difficulties and the impact this has on their daily living. அவங்க வந்து நாங்க முதல் வந்து ஒரு ஸ்ட்ரக்சரா இருக்க வேணும். அது வந்து இன்டர்வியூ வந்து நாங்க அவையோட பேசிக்கல, அத பிறகு நாங்க வந்து மெயின் பிரச்சனை என்ன என்றுதான் நாங்க வந்து பார்க்க போறோம். இது எப்படி அவங்களுடைய ஒவ்வொரு நாள் வாழ்க்கையிலும் அந்த பிரச்சனைகள் அவங்களுக்கு பாதிப்பை உண்டாக்குகின்றது என்றதையும் நாங்கள் வந்து பார்க்க போகின்றோம். To begin formulating and make informed decisions about treatment or referral. So நாங்கள் வந்து formulate பண்றது எனக்கு தமிழ்ல தெரியாது. யாராவது சைக்காலஜி ஸ்டூடெண்ட்ஸ் ப்ளீஸ் நீங்க எனக்கு டைப் பண்ணி எனக்கு ஹெல்ப் பண்ணுங்க. To begin formulating ன்னு சொன்னா அந்த எல்லா பிரச்சனைகளையும் வந்து எப்படி இது வந்து நடக்கிறது அப்படின்னு பார்த்து, அப்படி நாங்க ஃபார்முலேட் பண்ணின பிறகுதான் நாங்க இன்ஃபார்ம்டு டிசிஷன்ஸ், அப்ப கிளியர் டிசிஷன்ஸ் வந்து மேக் பண்ணலாம். எப்படி என்ன ட்ரீட்மெண்ட் இவங்களுக்கு கொடுக்கணும், அல்லாட்டி நாங்க இவங்களை ரிஃபர் பண்ணணும். ஏன்னு சொன்னா CBT is for anxiety and depressive disorders. யாராவது அதை பற்றி கதைக்க விரும்புறீங்களா? நாங்க சோ என்னத்துக்காக நான் வந்து ட்ரீட்மெண்ட் அண்ட் ரிஃபரலை பற்றி கதைக்கிறேன், அதை பற்றி நீங்க ஏதாவது சொல்லுங்க. எனக்கு தெரியுது அப்ப நீங்க வந்து ஃபாலோ பண்றீங்கன்னு. So please do let me know why. So when it comes to CBT, why we are talking about formulating treatment and referral? Why not just treatment? Shall we talk about it? Please, you can start typing. I'll give you 5 minutes. You can think about, I'll give you some clues. So what are we treating when we are using CBT? and who can we treat, who can't we not treat, and why are we making referrals. So give some thoughts, think பண்ணுங்க, think பண்ணிட்டு நீங்க வந்து type பண்ணுங்க. நாங்க எல்லாரையும் ட்ரீட் பண்ணலாமா CBT யூஸ் பண்ணி? Can we treat all the people using CBT? What do you think? There is no right or wrong answer here. I think you are thinking, or you are all thinking too much, thinking like, okay, there must be a clear right answer here. So please don't think like that. Just type whatever that comes to your mind, or you can speak whatever comes to your mind. And the psychology students, உங்களுக்கு விளங்கினதா கேள்வி நான் தமிழ்ல வந்து கேட்டது? நான் வெயிட் பண்றேன்னு என்னட்டு சொன்னா நாங்க ஃபாஸ்டா மூவ் பண்ணி பிரியோசனம் இல்ல. இது வந்து ஒரு இம்பார்ட்டன்ட் டாபிக். அப்ப நீங்க டைப் பண்ணுங்க, அப்ப எனக்கு தெரியும் என்ன நீங்க திங்க் பண்றீங்கன்னு. அப்ப அதுக்கேற்ற மாதிரி நான் உங்களுக்கு பதில் தரலாம்.
Hello. Yes, Meera. So, what were you asking specifically? I couldn't get the question.
You didn't understand the question?
Yeah.
Okay. Let me repeat the question again. So the question is, I said our aim is to begin formulating, make informed decisions about treatment or referral. Sadia? So I was asking that, like, so why are we thinking about referrals? ஏன் நாங்க referral பத்தி யோசிக்கிறோம்? Why not use CBT for all the patients? So அதை பத்தி கொஞ்சம் சொல்லுங்க. So please do speak a little bit about that. What do you understand about this? Maybe I'm not making the question clear. So we are talking about formulating informed decisions about treatment or referral. So in terms of the referral, why are we thinking of making referrals?
So I'll just speak what I know about CBT first. In CBT, we are mainly focusing on the cognitive and the behavioral aspect, right?
Yes.
So when you're looking at in that point of view, we're mainly focusing whether if they need a behavioral therapy or if we need to include the usage of any sort of drugs like antidepressants and those sort of aspects. But in some scenarios, it may not be like that. Like we can't use CBT for all. It's not like a blanket approach.
Yes.
What I'm saying is that we have to specifically tailor it for each patient. So can I talk about a patient which I experienced in the wards?
Yes, you can.
If you don't mind.
So give me a
So I had this patient. She was a young girl, probably in her mid 20s, and she's a working girl. She's a programmer, and she was in a relationship. So what actually happened was she had
so Safar, just before move on, so ensuring not to kind of share any identifying details, just some of the things I need to know.
So she consumed some organophosphates, and she had come for organic phosphate poisoning, and she was managed in a medical ward. So initially when I had to speak with her, she was like very shy and not very revealing in that aspect. But the most uh, the most significant reason for that was because she was next to her parents. She didn't want to
Yes.
reveal any sort of
Mm-hmm.
details at that point. So
Mm-hmm.
what I managed to do was try to speak with the patient in a much more closed environment and got through to her and sort of connected with her in a sense
Yes.
and found out why actually she took the medications.
Mm-hmm.
Sorry, not the medication, the organophosphates
Oh,
and
yeah.
dealt with it. So the diagnosis which was made was she was on a borderline personality disorder,
Mm-hmm.
and in reality, like she in speaking with her, what I felt was that she didn't necessarily need that the a treatment in the first sense. It was just like a her own social issues and relationship issues with the parents because as far as I can see over here in Sri Lanka and in different cultures, especially in the Hindu culture, they have
Mm-hmm.
separate castes. Like they view each people in casting as
Mm-hmm.
when I say casting in the sense like it's sort of like a group of people, individuals. Like only these group of individuals are supposed to be in a relationship with these group of individuals. Like
Yes. Yes. Yeah.
if you're group X, like you can interact with mainly group X. You're not it's not
Allowed to
widely
interact with someone
accepted to
else.
interact with another group, like group X with a group Y. That sort
Yes.
of outbranching, even within the Hindu culture, also is sort of shunned upon.
Okay.
So over here, when I'm just mainly deviating off topic here. So here, why we are looking at this aspect is because whether we mainly need to treat them in an inward setting or we need to treat them in an outpatient, where you will be definitely sure that the patient will give you a certain follow up, and also
Yes.
that if mainly we are looking over here is for the key word is insight, whether they know their current condition
Yeah.
and are they aware of their current condition? And with that, we can mainly decide on whether they need a routine follow-up or they can come for a usual clinic visit or they need to be admitted and they need to be in a close observation. I hope I got
So,
my
so
message
sorry, I didn't
correct.
understand the last bit. Are you asking some questions there, or you were
No,
kind
no,
of
no, no,
telling?
no.
No, no, you were
Yeah,
just
yeah.
sharing. Okay, so that is really, really lovely. I'm so happy that you shared that, Safan, because that's really helping me to understand a little bit of context where you all are working and what you are doing. So you were right. You know, although you were saying, oh, you went away a little bit, actually, you talked about the culture and the issues you are facing because of the culture and how do you treat someone. Um, do you treat the culture or do you treat the person, or, you know, how do you deal with that? But certainly you do treat the person, because the thing is, like, the cultures, they have their norms, they have their things, and then it's a society issues, isn't it? It's a society. So in the society they have particular issue, which is quite difficult. So one of the thing is, this is the question, why did I ask that question that you just shared to? For an example, you said the client is suffering from borderline personality disorder. I'm not sure she is. She might be, but it seems like from what you have said, she's a well-functioning person. She's going to work and she had been managing things. I'm not sure how many times she tried to overdose herself, or she took any organic kind of thing that you have just shared. But what I'm trying to, so in terms of the diagnosis as well, you do need to give some thoughts, you know, where it is coming from. Is it culturally relevant, this diagnosis? Maybe that at home there was lots of pressure going on, she couldn't handle it because of the issues from the culture, and in order to regulate her emotions and feelings, she might have done what she had to do. Okay, I don't know, so I cannot comment on these things. But this is what you are sitting with when you are doing the diagnosis. You know, the cultural background, cultural issues, the personality, and everything else, and how everything play a part. And certainly, you were right when. If you had, of course, if there is if it's a child involved, certainly that you need to kind of think about having a parent there. If it is an adult and if she's consenting that she can speak to you, you know, it's one-to-one conversation, and that should be, we should go for that. Here, when people come to see us, we do see them like adults. We ask them, is there, you know, if parents comes in, is there necessary that you come with us? What's the purpose of it? Can we speak to the patient like individually and establish before coming to you? We will certainly speaking to you, but then we can bring you in, because I do that sometimes from people from different cultural background. Whereas, you know, mostly, I shouldn't be judgmental here, mostly from the English culture, the British culture, because we are basically adult service. They don't bring anyone to come into the therapy room. But if we are seeing people from Asian culture, you know, there is a possibility they might want to have their husband, or they might want to have their parents. And we always say, well, shall we speak to you? And do you think, you know, what's the fear? Are you scared of me? Are you scared of sitting with me? And if they say yes, then I say, all right, then let's bring him in. And can we work in such way that I can see you without your parents or your husband or whoever it is. So it's a good idea to kind of have that sense to understand, like you did. This patient was speaking to you because, you know, you were able to invite her and have that conversation. So maybe you also want to think about what does that mean in the culture of your hospital, or what does the act and things like that says about that. You know, are you able to see patients or not, and what does that mean? Will there be any complaint if you saw someone on and if the patient says something and you say something and things like that? So I don't know, these are the things you need to work out in terms of the context, boundaries, professional boundaries. Do you need to have a third person there? You may not want anyone to be there. And is that okay to go ahead? Do you record? Because here, now these days we are using video. So all the conversations are recorded. It's all videoed. But sometimes the patients may not give you consent to do that. They might say, no, I don't want to get recorded or videoed. So if you have recordings, then you have something to kind of say, let's listen to the recording. I didn't say this, you said this, or whatever it is. It's not getting in argument with anything. It's also protecting yourself as clinicians, and kind of, you know, there was something else in the clinical room. So, I mean, I think these are it's good we are discussing this, because we don't have any clear answers for all the issues that might come up. It's depending on the culture, it's depending on the context, it's depending on ethical guidelines that you have given. So everything play a part. And how do we navigate and find a right balance and create that relationship with the patients? Does that make sense? So thank you very much, Safan. This is very important, and you know, you have enlightened me, and I hope the other people feel confident enough to speak out the context and things like that. So certainly there are issues in terms of the cultures. You were speaking about the Hindu culture and the caste system and the difficulties there, and you know, so you need to think about it. You know, where to draw the boundaries and how to support people and safeguarding them, because that's the other thing we are thinking about. If they need to be safeguarded, that needs to happen. So let me share about a couple of things that happens here as well in different cultures, that we need to pay attention to. Some of the things that's fine, but some of the things the culture might do to not be acceptable. For an example, if the Southeast Asian culture, sometimes they want their daughters to marry when they are 16 or something, because they are frightened. They are here. For an example, people maybe from Bangladesh, Pakistan, and there's fear that they might get married to different cultures. So what they do is they almost like kidnap their when you are 16, you're a child here, and take to Bangladesh or something, there would be a forced marriage, something will happen. That is just to ensure, Safan, it's very similar, isn't it, what you have shared? It's to ensure, so they are only getting married into their culture, but so they kidnap them, and they take their daughters there, and they get married to someone, and even as a child. And what happens is then the child come back here, and she doesn't want to know the husband, and she maybe runs away or report to the GP, and then the GP offer protection and contact the police, and the parents are certainly, they would look like criminals because you don't do that, and the child usually removed. Or there is something called genital mutation that happens as well, and that is crime. So in certain cultures, certain things that happens, and they feel that it's okay to do that, but certainly in the eyes of the law, that can be a crime. So that is to be watchful of that as well. So be watchful of all these things as a clinicians, because you will be then sitting with lots of ethical dilemmas, and dealing with that. That's what we will be dealing with in our everyday life. Okay, so did you understand that? Anyone want to give us a comment about your understanding of what we have been talking about? And how does that make you feel? Maybe get in touch with your feelings and tell me a little bit about how does that make you feel? And certainly, I'm very grateful for Safan to open up this discussion and the difficulties that we might face when we are seeing patients. So would you like to kind of share, how are you feeling just sitting, hearing us talking and having conversations and reflecting on culture, ethical issues, boundaries? How does that feel? What is that you are getting in touch with? So you can type or you can speak. Okay, I'm simply waiting for you. I'll give you another 5 minutes. I know we are going to finish in 30 minutes, so it would be really good if you could, kind of give some thoughts and share your feelings as we are talking about these very difficult subjects that could evoke feelings within us. So anyone want to comment on that? How does that feel that we are able to kind of have these conversations? You have gone all silent here. So I really encourage you to kind of share something. முதல் சைக்காலஜி ஸ்டூடெண்ட்ஸ் உங்களுக்கு விளங்கினதா நாங்க என்ன கதைச்சோம் அப்படி என்று சொல்லி? என்ன இங்கிலீஷ்ல தான் கன்வர்சேஷன் இருந்தது. அதாவது நாங்கள் வந்து கல்ச்சுரல் டிஃபரன்சஸ், சஃபான் ஒரு பேஷண்ட்டை பார்த்தார், அது வந்து அவங்களோட டிஃப்ரெண்ட் அந்த அந்த டிஃபிகல்டிஸ் என்ன ஃபேஸ் பண்ணினது, அவர் தனியே பேசிக்கல, அவங்க வந்து அந்த பேஷண்ட் வந்து ஓப்பன் அப் பண்ணி அவருக்கு எல்லாம் சொல்லக்கூடியதா இருந்தது. ஆனா பேரண்ட்ஸோட நீ கேட்கல, அவங்க பயந்தாங்க அதை பற்றி பேசுறதுக்கு. சோ நீங்க உங்களோட ஃபீலிங்ஸ் என்ன, அதை நீங்க வந்து கேட்கல, உங்களுக்கு அப்படி என்ன ஃபீல் பண்றீங்க? இது ஒரு டிஃபிகல்ட் டாபிக், இட்ஸ் நாட் ஈஸி இல்லையா? என்னன்னு சொன்னா ஒவ்வொருத்தர் ஒவ்வொரு மாதிரி வியூ பண்ணுவாங்க இதை வந்து. நாங்க ஆனா ஆஸ் அ ப்ரொஃபஷனல் எல்லா டிஃபிகல்ட் டாபிக்ஸும் நாங்க பேசித்தான் தீர வேணும். ஏன்னு சொன்னா நாங்க வந்து ஒரு பேஷண்ட்ஸ் எங்களுக்கு வரைக்கல, அவங்களுக்கு நாங்க வந்து சரியான ட்ரீட்மெண்ட் அதில் கொடுக்கல, இது முக்கியம். சோ ஏதாவது சொல்ல விரும்புறீங்களா இத பற்றி? முதல்ல நான் பேசுறது உங்களுக்கு கேக்குதா? ஓகே ஓகே. நாங்கள் இப்படி பேசுறது உங்களுக்கு ஹாப்பியா இருக்கா இல்லாட்டி உங்களுக்கு சேடா இருக்கா? So how do you feel? What is that you are getting in touch with? Do you think that speaking like this is helpful or unhelpful? நீங்க எதுவும் unhelpful இல்லாட்டி helpful என்று கூட எழுதலாம். அதாவது உங்களுக்கு உதவிகரமா இருக்கா இல்லாட்டி உதவிகரமா இல்லையா நாங்க பேசினது? Okay, so it is helpful. Okay, how it is helpful? என்னண்டு இது உங்களுக்கு உதவிகரமா இருக்கு? யாராவது அன்ஹெல்ப்ஃபுல்லா இருந்தா தைரியமா நீங்க எழுதுங்க அன்ஹெல்ப்ஃபுல்னு சொல்லி நாங்க அதையும் பார்ப்போம். ஏன்னு சொன்னா இது சரியான முக்கியமான விஷயம் நாங்க மூவ் ஆன் பண்ணும்போது. ஓகே, நீங்க ஹெல்ப்ஃபுல் டைப் பண்றீங்க. சோ ஓகே, நான் அதை ஹெல்ப்ஃபுல் அப்படின்னே நான் யோசிச்சு கொண்டு ஓகே, நீங்க ரைஸ் ஹேண்ட் பண்ணினவங்க நேரடியாகவே பேசலாம். அன்மியூட் பண்ணிட்டு பேசுங்க. ஓகே, நீங்க எல்லாரும் ஹெல்ப்ஃபுல் அப்படின்னு சொல்லி எழுதி கொண்டிருக்கீங்க. ஸோ ஐ வில் லீவ் தட். அண்ட் ஏன் நாங்க வந்து ஃபார்முலேட் பண்றது, ஏன் டிசிஷன்ஸ் ட்ரீட்மெண்ட்டை பற்றி ரிஃபரலை பற்றி கதைச்சது. சஃபான், யூ ஆர் ஸோ ரைட் in terms of what you were saying. So CBT is for anxiety and depressive disorders. That is the short-term kind of therapy for these things. So we have nice guidelines here, which is kind of saying, okay, so 22 sessions for this particular disorder, 18 sessions for social anxiety, and this much amount for depression and things like that. So if you have something beyond that, such as borderline personality disorder, let's say that. So in terms of CBT, some people, they do use CBT for borderline personality disorder, but it like maybe 2 years of work that they might be providing. But mostly the evidence-based, research-based therapeutic approaches for borderline personality disorder is DBT. Okay, so that's DBT. So what we are looking at is, we are going to look at anxiety and depressive disorders. When you're coming in touch with your patients, if you're looking at them and if you're actually seeing somebody is suffering from anxiety and depressive disorders, yeah, certainly you can say, oh, well, that's for me, I am going to do some work with them. But if you assess them and you feel like, no, this person might not benefit from CBT, because CBT is researched only for these. And it's not researched in Southeast Asian population, neither the Tamils or Islamic people or the English people or the Tamil people. So that is something you need to kind of think about, or maybe do some research on how applicable it is for that particular groups. But here, when they did the research and they kind of find out, okay, this is working for white middle class population, right? That's where the most of the research had done for CBT. This is something you do need to know. And it works really well. And let me share, and I have been working, so it works well. And I have tried to adapt CBT for some people who are coming from different cultures, and that works really well as well. So these are the things you might want to think for the future and how you want to deal with these things. Okay. So let's move on. So now we are going to talk about assessment. So I think we will cover some aspects and we will have to move on. So when we are doing assessment, so we are doing assessment and problem analysis, and then what we are going to look at is how we are going to do the session, how we are going to gather information. So remember that we talked about information gathering, and we are going to do the Socratic questioning, but we are going to organize the session. I was hoping that we could do some of the things today, but we were unable to do it. So we are going to do some outcome measures. We have certain outcome measures for depression, for anxiety, for phobia, for some of the things. So we call that one is PHQ-9, other one is CAT-7, then we have the phobia scales, and we have something called VUSs. And those 4 measures, when patients are coming into our service, we already send them either through email or through post, something else. And if they are able to kind of read, write English, if they cannot read, write English, we will send them in their own language, those measures, so they can do it. And we know when they are coming in, we look at the measures, just look at the measures and say, oh, okay, these people, they are thinking about severe depression. This is a little bit like anxiety. And then after that, this is just really low skills of CBT kind of work, which we call or maybe I shouldn't have said low skills, and that's really bad. I take that word away. So what I'm going to say is more like step 2 level. Here we have like different steps in terms of CBT. So we offer something that is mild kind of CBT, and then we go to high intensity level, right? So we assess, so for them, so when they're coming into the service, that we kind of establish using those measures. Please type if you use measures. I'm going to continue to speak because it seems like you're not really talking today. So continue to type and I will read that. Do you use any measures? And if you do let me know what measures you are using when you are speaking to your patients, clients. And then once we have that, and we already have some idea about what is happening with them, and then you kind of move on to the risk assessment quite quickly. You can look at the PHQ-9, and question 9 is, do you have any suicidal thoughts, and do you have thoughts about harming yourself and things like that? So you see, I can, without even looking at the measures, I can say it because I have been seeing that measures for a long time. I kind of know all the questions in that measures. So the question 9 is asking a little bit about that. And if they score 3 for that, and what we say is, if they score 3 for that, that person is telling you that they are having suicidal thoughts every day. So we kind of move on quickly to risk assessment to really understand if this person is high risk, low risk, medium risk. What do we do with that? So that's the second aspects. We do that, and then we elicit the main problem. Yes, because we talked about whatever problem they are coming with, whether it's depression, whether it is anxiety, we are getting the main problem. And then when the problem started, and what is the main presenting symptoms, and I call it uses a funneling process to gather full information, elicit emotional, autonomic, behavioral and cognitive symptoms, which we already talked about that, because that's the 5 area we talked about. So you are eliciting in a particular way, asking particular questions, and then determine how this problem is impacting on the lifestyle. You need to think about this, because we always think about the functioning aspects. People might have problems, but how well are they functioning is very important. And that is what's the difficulty is. Are they okay with their family relationship, their marital relationship, their work? So that's what we are going to consider, because that's basically lifestyle that people are living. And feedback and problem stating summary. Problem stating summary is that you are stating, this is what we talked about, this is what you said that you are suffering from, and is this correct? And they might say yes, no, or they will correct you. Okay, so that's the session kind of organization. This is how we are organizing. We ask about the important problems, then we kind of ask about medication, past episodes of treatment, we ask drugs, alcohol, physical health condition, mental health such as, and also LTC, impact on the mental health. If they have a physical health, there is a possibility it has an impact on their mental health. For an example, people with diabetes often suffer from depression. So you might want to, if they have that, and there was a possibility they might also suffer from depression, we don't know. And so thinking about LTC, long-term conditions. Employment issues that might cause stress, anxiety, and low mood. Anything that affects the problem, make the problem better. Sometimes they would tell you this is the unhelpful thing that makes the problem better, and they might tell you this is what making the problem worse. And that could be domestic violence, bullying, failing an exam, loss of employment, or alcohol or drug use that can make the problem worse. I have a stress problem. I'm a medical student. I'm finding it really difficult to study and understand and remember all these terms. I'm suffering from stress, right? What makes the problem better? What makes the problem better is when I go for a run 30 minutes in the morning, I just feel calmer and I feel better. What makes it worse? Well, when it comes to evening, I get too stressed and I cannot manage it. So I just take a bottle of wine or something. And that makes the problem worse, because in the morning I didn't have, I'm in a vicious cycle. I haven't done lots of work. So really giving some thoughts to that, how you are going to talk about it. And trust the process, because all the clients are different. They will be reacting in a way, and you might want to kind of, be there when you're assessing, and trust the process of assessing and see how that goes. So some pictures for you to see. Some people will be interested in telling you, some people might not want to even look at you. So these are the things that you might want to look at, and the body language. And so you are learning from the body language. When you're going to start doing the interviewing, you might want to start with speaking about your name, your role, time frame. Okay, so I will be saying, my name is Meera. Well, I will be saying the full name. My name is Meera Bahu. My role is, I am a, let's say I am a high intensity CBT therapist, or I am a CBT therapist. Whatever that you might want to kind of say your role is. Oh, I am a medical professional, or I'm a psychology student who is studying psychology, but you know, using some of my skills and having a conversation with you. It's important you say you are a trainee, and if you're not qualified, you do need to say that to them, because that is being genuine. Some of you earlier on, when you were typing, you were saying genuine. So your role has to be genuine, and they do need to know your role. In case if they ask, you know, what is your education? What did you do? And if it is relevant, you do need to kind of let them know who you are. Okay, and the time frame. So this is when you're offering CBT therapy, right? So you are medical students. I don't know about your time frame and how much time that you would be spending with one patient. For an example, the doctors, GPs here, they have only 10 minutes. Whereas the CBT therapists, because they are actually doing some therapy, and they have 50 minutes. So in terms of this type of session, when we are kind of using like step 2 level, which you might not understand what that is, so forgive me. Step 2 level, and that could be like you know, 30 minutes, they might quickly kind of get hold of all the information, whereas us, that when you are kind of offering full kind of assessment, it's 50 minutes. Okay, so you need to, so that you are setting some clear boundaries: your name, your role, your time frame, and check the patient's full name, because we're ensuring you are speaking to the right person. And also giving them that respect. You know, that's your name, thank you for letting me know. And your service policies. Service will have policies, and each policies have certain things. For an example, when I am going to explain that, so my name is Meera Bahu. I'm a CBT therapist. I have 50 minutes today to speak to you, and I just want to check and make sure this is your name, this is your GP. That means that's the client's doctor, because all the patients here, they have their doctors. So we kind of say that doctor's name, because we will have already received the information of that doctor. And then we will be kind of checking the address and everything, or something. If people want to do that, you can do that. And then what we do is, whatever you share will remain confidential within the context of NHS. That means that's where, you know, National Health Service, that's what I'm working for. However, if there are any issues related to risk, that's when we break the confidentiality. And the reason is, we want to ensure that you are safe, and we want to bring safety to you by contacting our colleagues to ensure that you are protected during that time. Is that okay with you? So I am telling them, I'll keep everything confidential within the context of what? The service. There's a possibility some other clinician can come and access the information. And I am also letting them know it's confidential, but I might break it, because if you're talking about risk issues, I will need to talk to someone about it. So I'm very respectfully letting them know that's how it's going to go. And then giving a rationale for the measures that you are using. The reason that we are using the measures, and sometimes people don't like using the measures, so don't worry about it, that putting number to a feeling, but it is because that we are trying to understand where you are in terms of this level. If you don't have to do this in a perfect way, if it doesn't make sense, I'll be happy to explain to you. So something like that. So because we are getting the measures from them. Give me a second, because I just want to read some of the questions from the measures. I will send that to you, perhaps, that you can have a look at, you know, how it looks like. So give me a second. I'll just grab one so I can, yeah, I can kind of show you. Okay, So we have all the measures, which is like for depression, then there are almost like 9 questions. So it's like literally interest or pleasure in doing things, feeling down, depressed, hopeless, and that is all measured within the last 2 weeks. And if it is not at all 0, several days 1, more than half the days is 2, nearly every day is 3. So we are measuring how many days that they are suffering, and that is going to give us the severity of the problem. Trouble falling or staying asleep, sleeping too much, feeling tired, having little energy, poor appetite, overeating, feeling bad about yourself that you are a failure or let yourself down, trouble concentrating on things. So these are the typical questions we will have for depression. And the anxiety one is feeling nervous, anxious, on edge, not being able to stop or control, worrying too much about different things, trouble relaxing. So these are the aspects that we are trying to find out, some of the questions that we will be kind of already asking. And then describing the purpose and sections of the assessment session. Avoid too much jargon, because you would know your Tamil language, your English language, your Sinhalese language, you know, if any other languages you are using in Sri Lanka. So you might want to make it simple for the patient to understand. Pace the session and understand the patient's distress. So we are not kind of quickly going over it. And yes, you know, yes, it must have been very difficult for you. So that kind of listening and giving some feedback related to that. And in your interpersonal skills are important. Bringing warm, empathic tone, speak in a speed patient can follow you, so they can kind of, you know, listen to you, follow you. Use appropriate questioning style, clearly understandable, one at a time, open, specific, closed. We will talk about that. And don't normalize and don't reassure quickly. Seek clarification always. So you are asking them, it's almost like guided discovery, like Bhavana was saying. ஸோ நாங்கள் வந்து என்னத்தை பற்றி கதைச்சுனாங்கன்னு சொன்னா, எப்படி நீங்க இதை வந்து ஆர்கனைஸ் பண்றீங்க இந்த செஷனை, உங்களோட பேர், உங்களுடைய நீங்க யார் என்று நீங்க கிளியரா சொல்லணும். மற்றது என்ன நேரம், இது வந்து 30 மினிட்ஸா 50 மினிட்ஸா, எவ்வளவு நேரம் அவங்களோட பேச போறீங்க. பேஷண்ட்ஸை வந்து நீங்க வந்து ஃபுல்லா வந்து செக் பண்ணி அவங்களோட நேம், பேர் என்ன, எந்த ஜிபி எந்த டாக்டர்கிட்ட இருந்து வர்றாங்க, ரிஃபர் பண்ணினாங்களா இல்லாட்டி அவங்களா வந்தாங்களா, ஸோ அதுகளை பற்றி நீங்க செக் பண்ணணும். உங்களோட சர்வீஸ்ல வந்து ஏதாவது பாலிசிஸ் இருக்கும், உங்களுக்கு வந்து எக்ஸ்பிளைன் பண்ணி இருக்கும் என்ன மாதிரி கான்ஃபிடென்ஷியாலிட்டி சொல்லணும் அப்படின்னு சொல்லி. அதுல வந்து நீங்க சொல்லலாம், நீங்க கதைக்கிறது எல்லாமே கான்ஃபிடென்ஷியலா இருக்கும், ஆனால் உங்களுக்கு ரிஸ்க் இஷ்யூஸ் வரைக்குள்ள நாங்க பிரேக் பண்ணுவோம். என்னன்னு சொன்னா எங்களோட கொலீக்ஸை வந்து கான்டாக்ட் பண்ணி அவங்க உங்களுக்கு அந்த சப்போர்ட் தர்றதுக்காக. அப்ப நீங்க வந்து மெஷர்ஸை பற்றி கதைச்சினான், அதாவது வந்து டிப்ரெஷனை மெஷர் பண்றது, மற்றது வந்து ஆன்சைட்டி, பயம் சம்பந்தப்பட்டதை மெஷர் பண்றது பற்றி கதைச்சினான். அப்ப அது வந்து தமிழ்ல நீங்க அவங்களுக்கு கொடுத்தா அவங்க வந்து அதை செய்துட்டு உங்களுக்கு வந்து தரலாம், நீங்க பார்க்கலாம் அது எப்படி என்ன மாதிரி. பேசைக்குள்ள வந்து சிம்பிள் சாதாரண மொழியில வந்து பேசுறது, எல்லா நேரத்தை வந்து சரியா வந்து யூஸ் பண்றது, மற்றது பேஷண்ட்ஸை வந்து அண்டர்ஸ்டாண்ட் பண்றது, அவங்களோட பிரச்சனைகள் என்ன, சரியான குவெஸ்டனை வந்து, அதாவது கேள்வி கேட்கின்ற கேள்விகள் வந்து தெளிவாகவும் ஒரு தடவைக்கு ஒரு கேள்வியாகவும், ஓப்பனான கொஸ்டின்ஸ், மற்றது சிலதுகள் ஸ்பெசிபிக், சிலதுகள் மூடின மாதிரி க்ளோஸ்ட் கொஸ்டின்ஸ். அவங்களுக்கு நீங்க ஒரு பதிலும் சொல்லக்கூடாது, மற்றது நீங்க வந்து ஏதாவது உங்களுக்கு விளங்காட்டி அவங்கள வந்து கேட்டு கிளியர் பண்ணணும். நீங்க வந்து உங்களோட பாட்டுல யோசிக்க கூடாது, இப்படியா இருக்கும் அப்படியா இருக்கும்னு சொல்லி உடனடியாயே அவங்கள ஸ்டாப் பண்ணக்கூடாது. இது ஓகே எல்லாருக்கும் நடக்கிறது தான் அப்படின்னு சொன்னா அவங்க ஸ்டாப் பண்ணிடுவாங்க பேசுறத. அப்ப அவங்கள கியூரியோசிட்டியோட நீங்க வந்து கேட்க வேணும். மற்றது வந்து கூடுதலா ஓகேன்னு நீங்க கூடுதலா அவங்கள வந்து காம் பண்ணினீங்கன்னு சொன்னா அவங்க சில வேளையில மிச்சத்தை கதைக்க மாட்டாங்க. சோ அதனால மற்றது வந்து கிளாரிபிகேஷன், இப்ப என்ன பிரச்சனைன்னு சொன்னா அந்த பிரச்சனையை வந்து நீங்க எந்த நேரம் கிளாரிஃபை பண்ணணும். So we have 6 minutes left. Organization of the sessionக்கு வந்துட்டோம். இவ்வளவுதான் நீங்க வந்து செய்யறீங்க. ஆனா we have to talk about a lot of things. Maybe we will do some role play next week. I'll send the measures. அப்ப மெஷர்ஸை வந்து நான் சென்ட் பண்ணின பிறகு நாங்க கதை கேட்கல வந்து நாங்க யாராவது எனக்கு உதவி செய்தா நாங்க வந்து ஒரு ரோல் பிளே வந்து நான் காட்டலாம். ரோல் பிளேன்னு சொன்னா இப்ப நான் பேஷண்ட் ஆயும் நீங்க வந்து டாக்டரோ ஒரு சைக்காலஜிஸ்டோ அப்படி இருந்தும் அல்லாட்டி நீங்க பேஷண்டா இருந்தா நான் அந்த கேள்விகளை கேட்கிற மாதிரியும் நான் உங்களுக்கு செய்து காட்டலாம். அதாவது வந்து நெக்ஸ்ட் டைம் எப்படி வந்து நாங்க இதை வந்து செய்யறதுண்டு. சோ ஏதாவது கொஸ்டின்ஸ் இருக்கா இன்னைக்கு? நீங்க வந்து ஐ வாண்ட் டு கீப் திஸ் 5 minutes. என்னன்னு சொன்னா பெருசா நீங்க இன்னைக்கு ஒருத்தருமே பேசல, அதனால உங்களுக்கு உங்களோட விளக்கம் என்ன மாதிரி அப்படின்னு பார்க்க விரும்புறேன். என்ன விளங்கி கொண்டீங்கன்னு நீங்க டைப் பண்ணலாம். இந்த உங்களுடைய கருத்து என்ன இந்த இந்த பகுதி பற்றி உங்களோட கருத்து என்ன? How do you feel about this session? And where do you think that you are understanding this? You know, did you have any feelings? ஏதாவது உங்களுக்கு ஒரு feelings வந்ததா? இது நல்லதா போகுது, சரியில்லாம போகுது அப்படி என்று சொல்லி. So whatever it is, you can give me feedback because we will be ending in 5 minutes. Let's use this 5 minutes and talk about it. Okay, சொல்லுங்க. So we are not going to move on to anything, just feedback. நாங்க வந்து எங்களோட செஷன் வந்து எண்டுக்கு வருது. இன்னைக்கு நாங்க கதைச்ச விஷயங்களை பற்றி நீங்க ஒரு ஃபீட்பேக் வந்து எனக்கு வந்து கேட்கிறேன். ஏதாவது எண்ணங்கள், ஏதாவது உணர்வுகள் உங்களுக்கு வந்ததா நாங்க பேசிக்கொண்டிருக்கேக்கல அதையும் கூட நீங்க வந்து எழுதலாம். So how do you feel about this session? What's your feedback? Usually Safan and Bhavana is the one who always speaks, so you know you can also type or speak to me, and the others you can also, I will encourage you to speak or type. Session helpful இருந்துச்சுதா unhelpful இருந்ததா? Because நாங்க இன்னும் 3 நிமிஷத்துல வந்து இது finish பண்ணப்படும். So நீங்க ஏதாவது feedback சொல்லுங்க. Okay, so Bhavana, thank you very much for this. So it was really great conversation today, talking about things that we should definitely consider and practice. Okay, so thank you for that. So anyone else? Today's session is very useful. Okay. So thank you for that. நீங்க வந்து டைப் பண்ணிக்கல மேபி ஏன் யூஸ்ஃபுல்லா இருந்ததுன்னு கொஞ்சம் திங்க் பண்ணுங்க. ஏன்னா இந்த ரிஃப்ளெக்ஷன்ஸ் எல்லாம் வெரி குட் இன் சைக்காலஜி. ஏன்னா அது ஒரு உங்களோட ஒரு ரிசர்ச் மைண்டட் பர்சனா வந்து உருவாக்கும். அப்ப நீங்க வந்து செஷன் ஹெல்ப்ஃபுல்லா இருந்தா that's very nice. I'm glad to hear all that it has been helpful to you and useful to you, but you might also want to say why. Okay, it's useful session, how we can diagnose and refer people, and how we can start a session and we can get some knowledge. So that's really good to hear that as well. Okay. Yes, I mean, we didn't cover a lot. Today we talked about, you know, cultural aspects, which is very, very important. Don't underestimate these aspects because they are paramount and very, very important aspects. And we will move on and we will do some role plays. And one of the things I am expecting to help me out when we are doing role plays is to come forward, to keep speaking to me. Okay, sure. Okay. So there is a Nushara raised hand. If you want to say anything, you can say that, Shara. Okay, so, okay, we can't break the patient's culture and beliefs. Yeah, we don't want to as well, because when they are coming from a particular culture and beliefs, we don't want to break theirs. Certainly not. We want to help them. We want to support them, right? So the idea of CBT, I don't want people to get the wrong idea. The idea of CBT is to not to disturb anybody's culture. That's why we are talking about it here very, very openly. The reason is because we need to offer lots of respect to the culture and their practices and everything. And we will be sitting with lots of difficult ethical dilemmas. Ethical dilemmas என்னன்னு தமிழ்ல சொல்றது? யாராவது எனக்கு உதவி செய்யுங்க. ஏன்னா இது வந்து சரியான முக்கியம். நான் இது வந்து உங்களுக்கு சொல்றது. எனக்கு தமிழ்ல உதவி செய்யுங்க. ethical dilemmas அப்படின்னு சொன்னா அப்படி என்னன்னு அதை வந்து தமிழ்ல வந்து சொல்லுவாங்க. ஒரு சமுதாயத்துல கலாச்சாரத்துல சில பிராக்டிசஸ் வந்து நடக்கல. அந்த பிராக்டிசஸ் வந்து ஃபர்ஸ்ட் ஜெனரேஷனுக்கு அக்செப்டபிளா இருக்கலாம், செகண்ட் ஜெனரேஷனுக்கு அக்செப்டபிள் இல்லாமல் இருக்கலாம், தேர்ட் ஜெனரேஷனுக்கு தெரியாமல் போகலாம். ஓகே, அந்த கல்ச்சர் எப்பவுமே எவால்வ் பண்ணி கொண்டு இருக்கும். அப்ப நாங்க ஒருத்தட்ட கல்ச்சரும் பிரேக் பண்ணக்கூடாது, ஒருத்தருடைய பிலீஃபும் பிரேக் பண்ணக்கூடாது. that can be crime. if you did it, it's crime, right? You don't go and do that. So we need to be respectful of others' culture. But certain cultural practices might be against law. For an example, நான் ஸ்ரீலங்கா பற்றி கதைக்க வரையில, இப்ப நான் வந்து இங்க கதைக்கிறேன். எந்த கல்ச்சுரல் பிராக்டிஸ் வந்து லோவுக்கு வந்து பிரச்சனையா இருக்கும்னு சொன்னா, let me talk about Middle East or you know, some of the countries from there, because it's not part of உங்களோட இடம் இல்ல, வேற இடம். சோ அங்க வந்து ஓகே, ஆப்பிரிக்கா பற்றி பேசுவோம். அப்ப ஆப்பிரிக்காவில வந்து சில கண்ட்ரீஸ்ல வந்து இந்த ஜெனிட்டல் மியூட்டிலேஷன் அப்படின்னு சொன்னா, பெண்கள் இது வந்து அவங்களோட கல்ச்சர், அவங்களோட ரிலிஜியஸ், ஆக்சுவலி இட்ஸ் ரிலிஜியஸ் பிராக்டிஸ் படி அவங்க அப்படி மியூட்டிலேஷன் நடக்கிறது. அதே பிராக்டிஸை அவங்க இங்க வந்து ட்ரை பண்ணுவாங்க. அப்ப அது கிரைம். இந்த கண்ட்ரில வந்து அப்படி ஒரு குழந்தைக்கு நீங்க வந்து செய்ய முடியாது. சோ அது வந்து ரியல் கிரைம். அப்ப ஜிபிஓ யாராவது ஃபைண்ட் அவுட் பண்ணா உடனே வந்து அவங்க வந்து அந்த குழந்தைய அவங்கள்ட்ட இருந்து ரிமூவ் பண்ணிடுவாங்க. ஏன்னு சொன்னா அவங்க அந்த குழந்தை ஆபத்துல இருக்குது என்றதுதான் இந்த கல்ச்சர்ன்ற வேற முறை. ஆனால் ஆப்பிரிக்காவில அவங்களோட நாட்டுல அவங்களோட கல்ச்சர்ல அது அக்செப்டபிள். விளங்குதா? அப்ப நான் என்ன சொன்னதுன்னு சொன்னா, சில விஷயங்கள் சில பேருடைய கல்ச்சருக்குள்ள அக்செப்டபிளா இருக்கும், சில விஷயங்கள் சில பேர்ட்ட கல்ச்சருக்கு அக்செப்ட் இல்லாம இருக்கலாம். ஆனா அப்படியான பேஷன்ஸ் தானே நீங்க பார்க்க போறீங்க. உங்களோட மனதுக்கு அக்செப்ட் பண்ணாத ஒரு ஆளை பார்க்க போறீங்க. அப்போ எவ்வளவோ ரெஸ்பெக்ட் நீங்க வந்து கொடுக்க வேணும். அப்போ ஒவ்வொரு கல்ச்சரும் மற்ற கல்ச்சரும் நீங்க அறிய வேணும். அப்ப நீங்க சிட் பண்ணுவீங்க என்னத்துல? எத்திக்கல் டிலமா. அதைத்தான் நான் வந்து சொன்னேன். நீங்க தமிழ்ல யாராவது எனக்கு சொல்றதுன்னா இதை சொல்லுங்க. அப்ப அதுல நீங்க சிட் பண்ணித்தான் இந்த ஒர்க்கை வந்து செய்ய போறீங்க. So you need to give some thoughts. அதுக்கு நீங்க கொஞ்சம் திங்க் பண்ணணும். அப்ப நீங்க திங்க் பண்ணிக்கல, இது கிரைமா? Is it a crime that's happening? No, it's a crime. It's a cultural practice. Lawல சொல்லல நீங்க அப்படி செய்யக்கூடாது, இப்படி செய்யக்கூடாது. Then it's okay. Then you have to respect their culture and you need to work sensitively with them. உங்களோட மனம் வந்து அதுக்கு அக்செப்ட் பண்ணாட்டி. ஆனா உங்களுக்கு கஷ்டமா இருந்தா நீங்க சொல்லலாம், I'm recognizing my limitation. எனக்கு வந்து இந்த ஒர்க் பண்ணலாம இருக்கு அப்படின்னு சொல்லி. அப்ப மற்றவங்க வேற ஒரு ஆக்கள் வந்து பார்க்கலாம். So it's just உங்களை நான் திங்க் பண்ண வச்சு நான் இன்றைக்கு. So it's not about breaking anybody's culture or beliefs. So my understanding on CBT has improved. This session helped me to promote skills like active listening, better communication skills, and cultural aspects which we have to consider while seeing patients. Oh, thank you so much. That's a lovely description. So I'm kind of feeling that, you know, you are really understanding it. ஏனென்று சொன்னா, so you know, some of the conversations we are going to have will evoke uncomfortable feelings. எங்களுக்கு வந்து uncomfortable-ஆ இருக்கும் சில விஷயங்கள் கதைக்கிறதுக்கு. ஆனா நாங்க கதைச்சே தீர வேணும். அந்த uncomfortable நாங்க feelings வந்து நாங்க overcome பண்ணணும். So we have to kind of think about how we can overcome all these uncomfortable feelings, start discussing about culture, start discussing about other people and making our relationship better. And that creates a better community, better society as well, as better service for your patients. Okay, in that note, I will leave you, and thank you for giving so much, taking time to think and give me that feedback. So we will move on more in terms of assessment next week. Okay, so thank you very much for today. Sambhavi?
Yeah. Hello.
Okay. Hello, Sambhavi. So நாங்க வந்து இன்னைக்கு end பண்ணுவோம் session. Okay. So எல்லாருக்கும் நன்றி, வணக்கம். Thank you.